Dana here with Dr. Al-Ghoul of Clarity Laser Vision. We're located in Calgary, Alberta, for those who don't know. Today we are going to talk about LASIK SBK and answer some questions that we've had come through. So we'll just start with a little introduction here. Dr. Al-Ghoul, you are surgical director here. How old is Clarity?
So Clarity's now about 4 years old, actually. Yeah,
Okay.
we started, I've been doing cardiac surgery for many more years than that, but we started Clarity Laser Vision several years ago. We actually initially started doing laser cardiac surgery out of another surgical center, and we opened our premise, I think it was March 2017, I would say, but we were doing Clarity Laser Vision prior to that at another location. But yeah, thank you. Just again, another recap of myself. I'm Dr. Al-Ghoul, corneal specialist here in Calgary, Alberta for the last 10 years. We have both CMA Eye Care Center and Clarity Laser Vision. Clarity Laser Vision, which is what we're talking about today, is a center dedicated to corrective surgery. Our philosophy is no compromise in everything we do, from the moment you walk in to the moment you're done with everything regarding the procedure. So, shall we start?
Yeah, so we are talking about LASIK SBK today.
Yeah.
One of the many refractive surgeries that we do here. Do you want to give us just a little overview of LASIK eye surgery?
For sure. I mean, 2 weeks ago we talked about PRK. Just a little recap. The excimer laser is this laser technology that was actually discovered through IBM. And it was patented by them initially and then went on to being utilized in various disciplines, but in the world of ophthalmology, several colleagues of ours started using the technology. Initially, we started doing PRK, which was FDA approved in 1995. And then in 1998, we actually got the FDA approval for a LASIK procedure. A little recap on the whole concept of what LASIK is versus PRK. So what we're talking about is the cornea, which is, again, this very thin structure, 0.5 millimeter thick, that's responsible for 2/3 of our ability to focus things. And what we're doing is we're using a laser that's ultra precise in removing tissues at micron scales. And what we're going to be doing is flattening the cornea or steepening the cornea, depending on what we're trying to correct in microns to achieve an improvement to the vision. So with PRK, what we do is we essentially do laser directly onto the surface of the cornea, but the initial top layer, which is about 50 microns, give or take, needs to be removed. That means more recovery is required with PRK as a result of removing that layer that the body is going to be required to heal. LASIK, on the other hand, is the concept of making a flap, usually traditionally about 160 to 180 microns deep. You lift the flap, you do the ablation in the deeper layers, akin to what you do with the PRK in terms of the amount of correction you do, but deeper into the cornea. Then you put the flap back on, and then you're done with the procedure. So the outcome is the same. The target, for example, if someone is nearsighted, is to flatten the cornea centrally. Let's take, for example, someone who's a -2. On average, that comes out to about 30 microns of tissue that you have to ablate or essentially remove. So you could do it with the PRK, you could do it with LASIK. The advantage to the LASIK is you're essentially maintaining the top layer. And when we talk about the cornea, we often mention that the cornea is about 100 to 200 times more sensitive than any other part of the body. So when you are leaving the top layer of the cornea intact, and then you're doing the ablation in deeper structures, putting the layer back on, there's very little discomfort experienced by the patients the next day and subsequently. And that's why LASIK became fairly popular. Just a little bit of a trivia, actually. LASIK started back in the 60s, believe it or not, back out of Bogota, Colombia, by a gentleman named Dr. Barker, and he thought of the idea of doing this, but at the time, of course, lasers weren't approved. So it was just the thought process of removing a layer of tissue that's within the cornea that then would lead to the improvement in outcomes. But yeah, that's in a nutshell the difference between LASIK and PRK.
And we're talking about LASIK SBK, which is what we mostly do in our clinic. So what's traditional LASIK versus SBK LASIK?
Great question, Elena. So the difference between traditional LASIK and SBK is the concept of how do we minimize issues pertaining to creating a flap. So traditionally, when LASIK was being performed many years ago, and in certain centers still the case, they would use a blade to make the flap. So, we don't use blades because we believe that lasers are far more refined, and studies definitely prove that. But if you were to use a microkeratome, a blade, typically the average thickness is in the range of about 150 to 160 microns deep. With SBK or subbowman keratomillusis, what we're doing is we're using a finer or a thinner flap, I should say, to make the flap for the correction. So our usual corneal flap is about 90 microns as opposed to 150 microns. When you compare the precision of what a femtosecond laser, so this is a different kind of laser we're talking about. So there's the excimer laser that's done to ablate the cornea, but then there's the femtosecond laser that is done to make the actual flap.
Right.
The femtosecond laser has been proven to be far more accurate in making a thinner flap, and the standard deviation, in other words, the precision of what I'm targeting. So if I'm saying I want 90 microns, the likelihood of achieving 90 microns is far greater with a laser approach to doing the flap than a mechanical approach. So SBK, in a nutshell, is really a finer flap that you're making. But there's more to it than that. I think the lasers themselves, the femtosecond laser, we're now at a 5th generation femtosecond technology. And so what's unique about the system that we have is the ability to design the edge of the flap to essentially tuck itself under the patient's own cornea. So one of the things we worry about with SBK surgery, and it's always mentioned with our patients, is about 1 in 2,000 chance that if something was to hit the eye, for example, there's a risk that the flap could dislocate. And that's the thing that we advise our patients if they're going, for example, to join the military or certain activities, job careers, I should say, that they're likely to do better with PRK than LASIK. But and interestingly enough, if you look at what the requirements is from our own Canadian Army, they would actually prefer PRK over LASIK. They are okay with LASIK, but they prefer PRK. So, sorry, kind of going off tangent here a bit on that, but going back to what I was saying is that basically the femtosecond laser would allow us to not just create a thin flap, but also the edges would be such that it's less likely to be lifted off in case of a trauma that could happen to the eye. Now, just to kind of give an idea, the kind of trauma that we mention are typically things are quite aggressive or severe to the eye. Something is really sharp that comes at the eye that has to come at a certain edge. And if you think of the way the microkeratome, the mechanical approach to make the flap sort of ends up being kind of this way, right? And so if something was to hit the eye on an edge, it probably could lift the flap. Whereas if you could tuck the edge of the cornea under the patient's own cornea, even if something was to hit the eye, the thought process is it's less likely to cause an issue with the SBK technique. Anecdotally, through some reports here and there, is that also if you're making a thinner flap, there's less likelihood of as much corneal nerve damage, and hopefully less likelihood of dry eye issues if you did a 90 micron flap as opposed to, say, 150 or 160 micron. And the other thing I'll mention is this risk of ectasia, where the cornea can become a bit irregular. This is again a rare condition that, again, if you have a deeper flap, 150 to 160 microns, you're more likely to develop that than to use a 90 micron flap. So that's really what SBK is about. It's a much more refined and secure way to do LASIK than traditional LASIK.
Okay, so it gives patients a little more peace of mind then. And maybe if they know they're drier, they've been turned on for LASIK in the past, would you say maybe they're a candidate now?
Yeah, so I mean, that takes me to the next point, and that is to talk about the things that the side effects and the complications, if you will, that could happen with LASIK surgery, or SBK surgery, we call it. If you look at the studies, and there's been many studies that looked at the complications and the things that could happen, you know, the number one thing that we worry most about is dry eye disease. And being in a dry climate like Calgary, you know, it's more of an issue, of course. And so that's where, if you look at how we approach our patients when they come in for assessments, we're doing a lot of testing specifically to look for risk factors like dry eye disease. So, you know, our thought process and the concept of the no compromises in the sense of actually detecting dry eye disease much earlier than traditional methods are used to detect dry eye disease. So we use more advanced technologies to look for that. And in ensuring that we don't see any subtle findings of dry eye disease, we're less likely to have issues of patients developing dry eye disease. And again, that's not just me, but based on studies, there's been many reports that show that, you know, there's a lot of cases of patients who may have findings of dry eye disease, but not necessarily have symptoms,
Right.
who may have not been detected prior to any corrective surgery, who then become symptomatic after. And those are the cases that, again, if we're coming in for our assessment, we would detect these, potentially hold off or postpone corrective surgery until we address the dry eye condition that they may have completely, and then may consider options like corrective surgery if the surface stabilizes enough to proceed with corrective surgery.
Right. So that would be that patient already has diagnosed dry eye. We're treating that. Potentially, we could still then do LASIK after.
Yeah, and I always mention, like, when you look at the studies and compare, for example, LASIK to PRK to something like ICL, we always say, look, in the first year, there is more prevalence of dry eye with LASIK as opposed to PRK. A year out, there's been no evidence to suggest there's more dryness developing after that. But comparing LASIK, PRK, ICL, which we'll talk about maybe next time, has the least likelihood of causing dryness. Then you got the PRK, then you got the LASIK. I will say that most of the time, the far majority of patients who do have dry eye symptoms after SBK or LASIK are likely to fully recover afterwards. It's a subset, a small percentage of patients who may have ongoing issues, and that's where, again, we believe, at least certainly it's been through our experience, that if we have detected dry eye disease at a much earlier stage, treated it, in a way we've improved the resiliency of the whole eye to undertake a procedure like LASIK and recover a lot faster from it.
Okay. One question I have had a patient ask is, will their eyes look different after surgery?
You know, to be honest with you, no. Like, you're not going to notice any difference. Immediately after the procedure, you might, because when we do SBK surgery, we are using that laser, and in order for us to make a flap, we have to apply a suction on the eye. It's nothing sharp. It's a suction that's applied on the eye. You may feel a bit of a pressure. You'll notice the vision go down a bit during that process. The whole thing takes about maybe 45 seconds, give or take, to do the actual process. But in applying the suction, sometimes you get a little bit of a reddish spot on the white of the eye, which resolves typically within about a week or so. But other than that, like, after a few weeks, you're not gonna see anything different with your eyes.
So when would someone be okay to return to work?
And that's the beauty of LASIK or SBK, is that when you compare it to PRK, you're definitely more likely to come back to work a lot sooner than traditional PRK. Now, again, with our TSA technique, we do find, certainly through many studies and our experience, that patients are recovering and getting back to work a lot sooner, typically within a week. But nothing compares to SBK or LASIK from the wow factor, from the recovery point of view, and that's why, you know, SBK and LASIK continues to be a fairly popular choice, because, you know, most people are back to work fairly quickly within a few days.
Right. And then as far as technology goes, you mentioned the femtosecond laser makes the flap. It's 5th generation. And then the one that resurfaces the eye, we have our 6th generation laser, the Schwind.
Correct.
So you have the additional safety features there too. How long is the whole process in the OR for the patient?
So, you know, a good estimate, I would say, is about 10 minutes.
Okay.
You know, it's probably what we're talking about. And then you're basically done, you know.
Okay. We had a patient email in. TJ says, I have astigmatism in both eyes. Can laser treatment help me?
Yeah, and that's why, like, you know, I've invested a lot of time and effort to actually go to these different centers. So, for example, the Schwind laser is based out of Frankfurt, Germany. So I actually went and explored all the different options, all the different lasers out there. I've actually literally pretty much went to the headquarters and those companies that I'm interested in and investigated why should I go with that laser. So it's again part of that philosophy of no compromise. So we wanted to make sure that we get the best of everything, whether it be the diagnostics, whether it'll be the technologies, whether it's the care, the aftercare. So in regards to that particular question, the reason I brought that up is because the Schwinn laser system, again, through many studies, has been proven to be the most effective in addressing astigmatism. And so many years ago, when we had patients come in with astigmatism, we would typically turn them down or just kind of give them caution that, look, you're not likely going to get as good of an outcome. With the Schwinn system, we have a 6th-generation system that tracks the eye in 6 dimensions, which is, again, far and beyond what the traditional laser systems are doing. But in being able to track the eye in such precise ways, we essentially achieve a number of advantages for our patients. One of them is really that ability to address the astigmatism very effectively. And I will mention that if someone comes in with a lot of astigmatism, we again always are basing our recommendations based on the evidence and the studies.
Right.
You know, studies do point that LASIK or SBK would likely do a better job in addressing higher levels of astigmatism than PRK. And again, that comes back to our concept of basically customizing our approach. So we're trying to align the right technology with the right patient. So it's not, we don't push people towards one technique versus the other. We truly believe, based on evidence, that certain patients are likely to do better with certain procedures, and that's why we offer all the technologies that are proven themselves to be effective.
Right. And then should someone have regression, their astigmatism coming back, would we do LASIK again or PRK? Where do we go from there?
Yes, another great question, Elena. So traditionally, there's more tendency to wanting to lift the flap if there was a regression and do the treatment and put the flap back on. And I would say clearly the vision, if a patient develops regression within the first year, which is very, very rare, we estimate that, especially in a myopic case, to be less than 5% of the time, then we would lift the flap in the first year and do the ablation, put the flap back on. If it's more than a year, the evidence out there based on the literature and the experience of many centers, including ours, is that doing a PRK treatment on a LASIK flap is likely to be more effective in those scenarios. But we always caution our patients that anytime you're doing a PRK on top of a LASIK or LASIK enhancement, there can be sometimes not as predictable of an outcome as if it was a virgin eye, if you will. Having said that, our results are typically quite consistent with what we wanted to achieve with patients who need enhancements.
Right. So if your ideal LASIK patient will walk through the door, what kind of prescription do they have, lifestyle?
Yeah.
Who does this appeal to the most?
Yeah, another great question, because I get that asked a lot. And, here's the thing, like there are centers now that really are very focused on LASIK. There are centers that are very focused on PRK. And I understand, and I get why certain centers kind of like to focus on one versus the other. Again, I think it depends on a number of factors. If we're talking about someone who's, joining the military, who's like a, MMA fighter or something like that, I mean, you're probably going to want to go with something like PRK as opposed to LASIK, because you don't want to be dealing with any possible issues of something coming at your eye, somebody jabbing at your eye, and you're kind of in a scenario that get some issues with the flap. And that's why there is recommendations out there for those things.
Right.
If you're someone who's got a lot of astigmatism, then again we kind of favor SBK over the we call it TSA, but basically PRK. If you got hyperopia or farsightedness, again, studies show you're more likely to benefit from LASIK or SBK in that scenario than PRK in terms of consistency of achieving that target. If you come in with a lot of refractive, or let's say someone like who's got a -8, -10, -11, I mean we've done up to -17, believe it or not, and if their eyes is healthy, those are cases that would be much better to do with ICL technology or the implantable contacts than something like LASIK or PRK. Because when you're altering the cornea to that extent, we start worrying more about things like dry eyes, things like other, more concerning issues that happen to the eye. So, and again, that's where we do tailor the situation. Another example, let's say someone's got, just this week actually, I saw a gentleman who has a rare corneal condition called anterior basement membrane dystrophy. So, we know in those cases that if he did LASIK, there's more tendency for them to get recurrent erosions, and they're more likely to do better with PRK. And that's where, again, the advantage of seeing a corneal specialist in your assessment preoperatively really is worthwhile, because we are looking for these subtle changes, right? Someone who's got another condition that's hereditary, Fuchs dystrophy, for example. If it's a mild amount, is not significant, they're more likely to do better with PRK there in that scenario, right? Somebody's got keloids or a history of developing a lot of scarring, they're better to do with LASIK or SBK than PRK. And again, that gets kind of confusing if you're trying to figure out yourself what's best for you, right? And that's where, again, the value of a very detailed workup using all these technology really pays off, in my opinion.
Yeah, and then the patient will meet you.
Yeah.
And get your opinion and be well informed. We did get one question, and I actually have been getting this a lot because I guess it's practice now where some clinics will offer and some clinics won't. But what is wavefront technology?
Yeah.
It's part of our surgeries.
Yeah, we basically, in our offerings, we don't even bother talking about a standard versus advanced. Like it's already included. In other words, you are getting the absolute customized approach to corrective surgery. And to talk a little bit more about it, and I apologize in advance because it get a bit kind of confusing, but if we're talking about glasses, for example, typically what glasses are correcting are essentially the lower order aberrations of the eye. In other words, when light strikes the eye, if you look at this model of the eye, when light strikes the eye and you're nearsighted, the light is focusing in front of the eye. And if you're farsighted, it's focusing on the back of the eye. And most of the error that we're correcting with glasses or contacts is about correcting these lower order aberrations, where we're taking the majority of the light rays that are entering the eye and focusing it to the retina. So the goal is to take all the light rays and not have it focus on the front of the eye or the back, sorry, not in front of the retina or back of the retina, but right onto the retina. And that's what glasses or contacts are doing. And essentially, when we started doing lasers, many years ago, that's the big thing that we're doing. The concept of customized wavefront guided treatments is to not just get the majority of the light rays to focus on the retina, but essentially take as many of the light rays to focus on the retina. And those light rays are measured in the definition of what we call higher order aberrations. And higher order aberrations are where basically the light rays are not essentially focusing on some of the light rays are not focusing on the retina. So by measuring the eye's corneal shape, the entire aberration of the eyeball, the lasers are able to correct that aspect. And that's why in many studies, there's a lot of respondents, a lot of patients will say that they notice their vision to actually improve compared to them just wearing glasses or contacts alone after corrective surgery, because we are taking those higher order aberrations and we're treating it. And so the concept of customization is something that we automatically are doing by measuring your eyes in so many different ways. And it goes kind of behind the scene in terms of how we look at deciding if it's a ocular-based customization versus corneal-based customization. Again, one of the advantages of the Schwinn is that was already incorporated far earlier than some of the other lasers that are kind of coming in now and saying, no, we have that. So again, that's some of the advantages that we don't talk a lot about with our patients. It's just kind of already incorporated into our offerings.
Yeah. Haley wants to know, would you advise to wait until you're done having children before you get corrective surgery?
So the key thing is actually more likely if you were pregnant. So if you're pregnant, what happens is a lot of fluctuations that can happen to the vision. So if we're doing corrective surgery during that time, we're not actually getting a clear sense of the true target that we're aiming for. And so I always think of corrective surgery as like you're an archer, you're trying to hit a bullseye. And so if your eyeball is continuing to change, then the bullseye is moving on us, so we don't want to do corrective surgery. If you're pregnant, there's a lot of fluctuations, and you don't want to do corrective surgery. So I wouldn't necessarily say that you have to wait till you get all your kids and then have corrective surgery. I would more say that you definitely want to wait after delivery for several months to make sure the vision is stabilized, and then do corrective surgery. And whether they want to have kids later or not, it shouldn't really impact too much on terms of the regression effect that could happen. I mean, corrective surgery is a permanent change and alteration to the cornea that happens. Your eyeballs change, sure, but that's incidence is in the range of about 5%, as I was saying. In hyperopes, it's a bit more than that, but sometimes that's more because the eyeball can change. The eyeball gets longer, and that could be the cause, as opposed to the corneal flattening effect reversing, if you will.
Right, so it's hard to tell what's pregnancy, what's your eye, the natural state, I guess.
Yeah, and that's why we wait. We want to wait till definitely you're stabilized, and we always ask the question, of course, are you pregnant? You're not. We want to ensure that someone's vision is really stable before we do anything.
Better safe than sorry.
Yeah.
Chandra Paul says, "Hi there. I'm a 60-year-old man wearing bifocals. Can this treatment help me?"
Yeah. So once we hit let's say 50 plus years of age, we do sort of look at LASIK. We look at PRK still, and then we sort of look LASIK, PRK, or what we call RLE, which is refractive lens exchange. Refractive lens exchange is a totally different technology, which we'll talk about at some point as well. And that's where we're going into the eye and replacing the natural lens with an artificial lens. Right. The reason I would bring up that discussion in someone who's 50 plus years old is because we all kind of reach that point where we have difficulty seeing up close. Even if you had perfect vision, once you hit 50 plus, maybe sometimes earlier, sometimes a little bit later, you start having difficulties focusing. And typically, laser treatment on the cornea does not do a very good job of correcting that, unless we sort of start creating scenarios like monovision or that sort of thing. So in a gentleman like 60 years old, we will say that, look, if the expectations are such that you're looking just to get your distance vision corrected and you're okay with reading glasses, then what's unique about LASIK or PRK, provided the lens and the rest of the eye is completely healthy, is it's less invasive than something like refractive lens exchange. If on the other hand, he's looking for an option, or she's looking for an option that makes them able to see distance and near, what we do have in that scenario are implantable lenses that can provide both of those functions. And typically we don't recommend them for younger patients because you can still focus up close, but for older patients, that become more of a viable option that we could explore with them.
Okay, but for someone, there is monovision.
Right.
And there's patients with natural monovision. There's patients who try monovision with contacts.
Yes.
Do you recommend trying, I guess, mimicking the surgery with contacts before you actually have surgery?
Yeah, we're really big advocates for giving our patients as much of a correlation between how things are gonna be like with surgery prior to them doing surgery. So often we can get a pretty good correlation, let's say at least a 90% correlation with contact lens trials. And often that's what I'll do with my patients who are sort of looking for these kind of unique situations like monovision or maybe multifocality with RLEs. We would put them through trials of contacts. And like I say, there's about a 90% correlation that if you like how contacts will mimic things, you likely achieve the same outcome with either laser procedure or RLE. So yeah, we're big advocates for trying to essentially giving our patients as much of an experience prior to surgery of what it would be like prior to them committing to surgery.
Yeah, kind of try before you buy.
Yeah, that's a good way to do it.
I have a question for you. I'm curious. It's always interesting to hear medical case studies. I want to know if you have any stories of a flap being completely dislodged.
Yeah, I mean, as a corneal center at CMI Eye Care, we deal with a lot of complications from various things that come our way, right? So I would say that, when you look at the history of LASIK, when they used to use mechanical, and again, some places still use mechanical,
Yeah.
but when you're applying mechanical techniques to doing the flap, historically there were risks of complete, what we call free flaps, or free caps, I should say, where the entire cornea could lift off, the flap, I should say. Less so now, even with the mechanical approach. I said less so. The technology has been refined even in that scenario.
Well, SBK will tuck under, right?
Yeah, so less likely. But you mentioned a story. I mean, there's definitely several stories I've had of like pet owners who like their cat would scratch and the nail would come in such a, it's just a kind of a freak accident, but just in that spot, and then it would lift the flap. Or, I had another gentleman who actually, he was like with his kids, and his kid had a fork, and I don't know what he was doing with the fork, but he kind of went up like that, and the fork actually came in the flap edge. And thankfully, in both of those scenarios, we were able to reposition the flap, irrigate, of course, put it back on, and it took a while, so probably about 3 to 6 months, but then 6 months out, they were back to their normal vision prior, which is, actually, I think both of them had about 20/20 vision. So, again, nice stories at the end of it all for them, but of course was quite scary for them going through that. And again, that's where, we do believe that if you have a thinner flap and a flap edge that allows you to tuck, that is less likely for that to happen. And the 1 in 2,000 incidents, when you look at the incidence of that report, it was typically with the mechanical microkeratome. We know with the laser approach to doing the flap, there's more adhesions, so more, if you will, scarring that happens at the edges. So again, less likely, but yeah, it could still happen. So those two stories come to mind.
Completely freak accidents.
Yeah, and honestly, things happen. Like unfortunately, life is such, when you're dealing the world of eyes, you see bad things happening all the time. Whether it's complications from contact lens uses, like infections, or complications from glasses. Believe it or not, and glasses break and they accidentally break in towards the eye, and bad things happen, right? So I would say honestly that things happen regardless of whether it's corrective surgery or whether it's contacts or glasses.
And you haven't had a case where it's become unmanageable, or being that you're on call right now actually for the city, so you see emergencies.
Thankfully nobody paged so far, so that's good. So in the context of LASIK and PRK, I would say there's no reports to date that if someone ever went kind of completely blind or anything like that. Okay, could infections happen? Absolutely. It's extremely rare. Thankfully, we just thankfully don't deal with it as much now. Partly because we're a lot more cautious in our aftercare. Partly because our antibiotic profiles, in other words, the type of antibiotics we have now compared to say 10 or 20 years ago, have become a lot more effective in minimizing any risk of infections developing as well. So usually when we think about like bad things happening, we always think of infections, to be honest with you. So in terms of infection developing post-corrective surgery, it's been a fairly long time since we had to deal with one.
Yeah, well, that gives people more peace of mind. We did actually have recently on W5, there was that expose on LASIK surgery. We had quite a few patients scheduled. This past Saturday, we had one patient, Angel. She was quite anxious. Had a lot of questions about it, and you had mentioned how we see more complications from contacts than induced from surgery.
Yeah, so the kind of, I gotta put my cornea hat on instead of the corrective surgery hat on. So, as a corneal specialist, we are aware of this condition, essentially neuropathic pain is what we call it. And the recent studies, the Dry Eye Workshop 2, actually formalized it in the category of basically symptoms without signs for our patients. And when you look at the underlying etiology of what's going on there, so patients who get this neuropathic pain can come from various walks of life. Some of my most severe patients actually are those who've had, one patient didn't really have anything. She just sort of developed it for no apparent reason. She just changed her working environment. She became quite dry, and it truly is, in my opinion, neuropathic pain. Other patient who has contact lenses that cause it. Other patients who had LASIK. Other patients who had cataract surgery. And you look at the etiology of neuropathic pain, essentially right now the thought process is some insult happened to the cornea that leads to the nerves getting agitated, that somehow the signal goes to the central part of the brain and makes our corneas hypersensitive. In other words, they just become really, the simple way to think of it, they really become anxious to any stimuli, whether it's wind, whether it's like cold solution or anything. It just becomes really sensitive. It's for sure a condition that could happen with PRK or LASIK or any corrective surgery, like I was saying. And I do have several patients in my practice who, like I say, come in from various backgrounds. The worst in my experience have been those who have come in from other things like cataract surgery and contacts. Some definitely came through LASIK and PRK. And it is one of those things that are a bit of a challenge to address, because the incidence of something like this is so rare. I mean, there's reports of it being 1 in 10,000. That when you have something extremely rare like that, it's harder to study. Thankfully, there are about 2 or 3 centers in the States who have sort of taken it upon themselves to do a lot more research into it. And again, thankfully, there's been more and more therapies that they've been able to successfully offer for these patients who get these really rare conditions. And when you look at what they talk about about 20% of their cases are those who've had LASIK or PRK. And so I mean, it is one of those things that could happen. It's rare, but like I was mentioning earlier, I just saw a lady a few weeks ago. Unfortunately, she was driving and the airbag deployed, and the airbag broke into the glass, and the glass broke and went into her eye. She lost her eye. I mean, does that mean cars shouldn't have airbags? Of course not. I mean, we know that we are far more likely to have patients' lives saved by airbags, but could bad things happen? Absolutely. I've had chemical burns happen from airbags. I've had a lot more, and if you look at the complications, and this is again proven, if you look at the incidence of complications from contact lens usage compared to LASIK, in someone's lifetime, if they were to continue wearing contacts, there's far greater likelihood they get complications like infections or other things than LASIK or PRK. And a big portion of my practice as a corneal specialist dealing, unfortunately, with these complications. And again, contacts is a fantastic option. I think it's it's not. I'm not blaming the technology, but the reality of life is that there are always risks with anything. And so I think the most important thing is truly to be well informed. I think that's the idea behind what we're trying to do. Our goal is to educate our patients about what LASIK and PRK and ICL and RLE can offer you, for example. It's not my role to downplay the potential risks, or I just say it as it is, and I give our patients the true, full, informed understanding of the things that could happen. And ultimately, you as a patient have to be comfortable and say, you know what, I'm comfortable with those risks. I'm comfortable with knowing about them. And what's good for us is that honestly we're quite comfortable dealing with all the complications. But that's why I'm always of the opinion that, look, there are things that go beyond what we see. Like, why could someone develop dry eyes after if they were to do corrective surgery? Well, we'll do our very best to employ all the technologies and all the expertise we can as of 2018 to absolutely minimize that possibility. So that means using all the technologies preoperatively to detect and treat dry eye disease, for example. I'm just using dry eye disease as an example. But let's talk about in general, right? Doing all the technologies we can to detect any issues, using all the technologies to maximize outcome, and using our expertise to be there for you throughout that journey. So that's why our patients get my cell number, and I'm checking on them the same day. We see them the next day. We see them in a week. We're wanting to make sure that absolutely that that initial recovery, which is the most critical part, the first week, I would say, in any corrective surgery procedure, is well looked after for our patients, so they don't feel like at any point they are not well taken care of. And I really believe that concept of no compromise, that philosophy, has really served us quite well, and we're quite happy with that approach. But yeah, I mean, complications happen. I think that report, I mean, it's good that it brought it to attention. I think that anytime there's reports brought in on TV or other media sources, it's good to be aware of the incidences and be comfortable understanding that. And that's why I wanted to mention a website. Elena just can't remember the name of it, which I think is a really like yeah. So it's the American
Refractive Surgery Council.
Yeah, American Refractive Surgery Council.org.
Yeah.
Because I mean, Google is fantastic for so many things in our lives, but I mean, it becomes a bit confusing when you're trying to find good information about, you know, a condition or complications. And so this website really does a nice job of taking, you know, again, the evidence-based approach to looking at corrective surgery. Another good website is the American Academy of Ophthalmology, which again will go into detail explaining the process of corrective surgery. And actually on that website you can download a PDF that talks about the risks in more detail. You're also welcome to use our PDF. We do have a free download brochure that does go in detail about all the potential complications that happen. So I would encourage you to look into that as well, so that you can kind of become more well-informed and comfortable with the notion of corrective surgery.
So that's at claritylaservision.com. You can download the free information booklet. And if you have any additional questions, you can send them in over Facebook and through our website. I think we'll end with one last question here. Mary had sent me an email. Dr. Al-Ghoul, do I get a warranty with my LASIK surgery?
Yeah, so again, part of the no compromise philosophy that we do is this concept of lifetime commitment. We automatically include that with our laser assessments and treatments for our patients. There are certain criteria that they need to be kind of having in order to allow that. So, you know, if someone, for example, is coming in for corrective surgery, their cornea is thin, and really the only option is ICL, for example, I wouldn't offer a lifetime commitment, because the lifetime commitment is based on the idea that we could do a laser touch-up afterwards in that scenario. So, you know, maybe not safe for that patient to have a lifetime commitment with laser, so that we would tell them up front, look, that wouldn't apply in that scenario. But the majority of our patients, I would say, do qualify, you know, automatically for this. And that's the reason we did that, is just because I really think that we think of our, you know, our service as a service. So it's the concept is that, you know, we want to be with you along the journey of having this, you know, excellent vision, hopefully after corrective surgery, and be there for you should there be any changes that happen along the way.
All right. So I think we'll end here for the night. This was Dr. Al-Ghoul. I'm Elena. Thanks for joining us here at Clarity. If you want to give us a call, 403-640-0400, or check out our website, claritylaservision.com. Thanks for joining us.